Hi, I'm Priya, one of the international faculty at HFAI 2025. It's my great pleasure to be at this conference. I'm having a great time. I will say I'm going to speak about GDMT, and I will say I have absolutely no disclosures. I have no pharmaceutical contacts or anything else. This is truly my personal opinion. It doesn't really reflect the opinion of any institution I'm associated with. Great meeting, and I had a lot of thoughts during this meeting. So I had an agenda when I came in to talk about two things. One was the role of guideline-directed medical therapies, and now what is becoming GDMT in heart failure with preserved ejection fraction, and the fact that there's just been a renaissance in this field. It's been a renaissance in how we describe HFpEF, what is HFpEF, and the subphenotypes of HFpEF. And one thing that became resoundingly clear, especially for the Indian subcontinent, is how relevant obese cardiometabolic phenotypes of HFpEF have become, especially for the subcontinent. So as we know, HFpEF has gone from being defined 25 years ago as really a disease of elderly, predominantly female, hypertensive patients who have atrial fibrillation. And it is now really this heterogeneous group of heart failure with increased or elevated filling pressures that have different subphenotypes. One of the biggest ones that have come into our clinical consciousness is this obese cardiometabolic phenotype that's really typified by three anchoring points, one of them being visceral adiposity, inflammation, chronic kidney disease, where the inflammation that comes can come from different sources. Hyperglycemia, visceral adiposity itself, where you have this deposition of visceral adipose tissue or epicardial adipose tissue that might be a reservoir of inflammatory cytokines, because fat, as we know, all fat isn't created equal, and especially in the Indian subcontinent, I think traditional parameters, things like BMI, are more anthropometric-based measures that will need refinement. It's not going to work for every population. So there are certain things like waist to hip ratios or waist to height ratios, body roundness indices that should probably be used in prognosticating and classifying patients. And I think that ends up being really important. And so to go back to the sort of the three macro system issues that kind of conglomerate for this obese cardiometabolic HFpEF: inflammation, CKD, and visceral adiposity. And all these three things, I think the big output from it is that circulating metabolites, the presence of inflammation, change energetics at both the myocyte level for both the cardiac myocytes as well as skeletal muscle energetics, and it really drives forward a lot of these phenotypes, and it ends up being really important to classify people in the right subtype of HFpEF to make them eligible for therapies that have truly moved the disease forward. Three classes of therapies that have really progressed in the last 5 to 7 years, I would say. One being SGLT2 inhibitors. We discussed the Emperor, Preserved, and the Deliver trials. Big studies that showed a huge benefit in decrease in heart failure hospitalizations for patients with an EF that's greater than 40%. The second group of drugs are a little bit newer, the GLP-1s. The Summit trial and the STEP-HFpEF study were really well represented at this meeting. A lot of people talking about the fact that heart failure hospitalizations for patients with heart failure with preserved ejection fraction really was improved, and a lot of that was tied into weight loss as well as the inflammatory marker CRP. Again, a connection between adiposity and inflammation, a very clear one. And then the third agent that we talked about was the non-steroidal MRA, so finerenone, and the fine art study that just came out recently. And I think there's more and more subgroup analyses that are coming out. This trial is pretty new, just came out at the end of last year. And I think there are subgroup analyses that really tie the benefit of finerenone and an augmented benefit perhaps in patients who have a higher BMI, working through a mechanism through delaying kidney disease as well as direct effects on the myocardium. So really a super exciting meeting at HFAI, and as somebody who spends a lot of time thinking about cardiac muscle energetics and heart failure with both preserved and reduced ejection fraction, it's a really exciting time in heart failure with the development of a lot of these precision-based therapies that are multi-pronged in approach and especially relevant for the Indian subcontinent, where the predominance of these different comorbidities is incredibly high. And are really a pitch for integrated management and more collaboration between heart failure cardiologists endocrinologists, and nephrologists, because all of these medications, I think, really have their side effect profile is not necessarily trivial, but I think the benefit of these drugs in collaboration with each other is so powerful. But I think it is probably the best employed when you have an interdisciplinary team of a cardiologist, an endocrinologist, a nephrologist, including a general practitioner, to manage multiple organ systems that have this really complicated relationship with each other to make sure that these drugs are deployed in a safe and effective manner.